All right. Well, thank you everyone for joining us. Disclaimer, I'm not a healthcare professional. I became interested in the topic because when I read the 2010 Race to the Top application that Missouri's Department of Elementary and Secondary Ed submitted to the U.S. Department of Ed, it included a statement that that Missouri would have a statewide longitudinal data system, and that student medical data would be merged with this statewide longitudinal data system. So when I became aware of the PDMP as a health record, I recognized that there were kids, my specialty was in learning disability, so there are kids who are on Schedule II drugs for attention deficit disorder. Ritalin and Adderall are included in Schedule II drugs. So I knew that they would be captured in the PDMP, and that there was going to be more to this. As Mary Kramer, another member of this group, had pointed out, if you have your wisdom teeth removed, dentists offer you opioids, and then suddenly you're in the record. But what did that mean in terms of who gets to see that data? And so it was a big question for us. So that's my disclaimer. I'm not a healthcare professional, but I do have a professional interest in this. I want to thank you again, whoever's recently joined. I want to let you know this is a panel presentation, that it's not just me who will be talking with you, but there are other members of the panel, including Ron Calzone from Missouri First, Mary Kramer, who's a chronic pain patient, and representing other patients as she tells you their stories and how the PDMP has affected their lives. Bev Allen, of course, who invited you, is Missouri's Director of Concerned Women for America. And John Lilly, Dr. John Lilly, has been a staunch opponent to PDMP, and an author of an article that was submitted at our hearing in
What did I do?
And then Ron Staggs, he's also been stalwart, coming every year to testify against PDMP. He's the Associate Commissioner of Monroe County. Then there's some housekeeping tips here. One is that this webinar is being recorded. The members of the audience, please mute yourselves to eliminate any background noise. Type questions into the chat box that you can see. Begin your question identifying which of these panel members you would like to have answer your question. If you direct it at any one of us and we feel a different team member would respond more intelligently or more informedly, we might defer to another panel member, but tell us what you're thinking. Mary Kramer, our representative chronic pain patient, will monitor the questions, and if the questions need clarification about the slide, she may allow your question immediately. If not, generally the questions will be answered at the end of the PowerPoint presentation. You're going to see a table comparing PDMPs and the Common Core State Standards Initiative. This PowerPoint, that table, and a longer in-depth PowerPoint that we're not going to show tonight will be emailed to you within 2 days after this presentation. And we would love your input, because there's going to be a second webinar scheduled for legislators. We're planning it for next week. And you can help us to refine this a bit more with your questions or suggestions. So with that, let me start calling up the table so that you can see. It was during the hearing of really against Holly Rader's bill, HB 1693, that I started hearing the same kind of arguments about data privacy, and there's no research that can validate that this is useful for its claims. And I'm wondering, where was I hearing this before? and I'd been fighting Common Core since 2010. So I started connecting the dots, and I realized that there were many commonalities between an initiative. So it's not just the standards, it's the whole initiative that's called the Common Core State Standard Initiative, which included a statewide longitudinal data system and performance assessments. So when I started connecting the dots as to what it meant to have systems thinking, I started looking at PDMP through the lens of all of the things I had learned about Common Core and organized them in this table. So what you need to understand is at the top, this is not a US initiative, all right? This is coming from an elite group who are managing global issues, including education and healthcare, from a position in the UN. And that might sound a bit conspiracy theory oriented, but stay with me here, I'm going to explain it. Common Core actually aligns with the mission of Bill Gates. You have to understand, Bill Gates is the second highest donor to the United Nations, well, to the World Health Organization in particular. But Microsoft, his company, signed an agreement with UNESCO. So Bill is all over the place up there, and he's very integral in the orchestration of both initiatives. In that, Microsoft and the technology involved there with the Common Core initiative has a lot to do with Microsoft software. As the funder of the World Health Organization, you'll see a great deal of technology being pushed into World Health Organization's resolutions, saying what we need is to gather all of this data and standardize it in such a way that we can basically upload it in spreadsheets. And you're going to see how these are very common. Both of them have a foundation of systems thinking. And systems thinking is grounded in economic theory. And if you understand that, you'll understand that the worldview of the individual is that it belongs to the state. So this is why there's such a contrast to what's typical in at least my thinking growing up of what the US Constitution meant for individuals, right? We were told that we had a creator and that we had rights that were unalienable. The UN doesn't view us that way. The UN views its mission as creating a beautiful society, not compassion for individuals. So it's in conflict with a lot of American culture, and in particular, education and health culture. So systems thinking is what's driving everything you're going to see organized. Know that there were key figures connected to the economy, all right? And Mark Tucker was the driver of accountability and standards in the education realm. Dr. Ezekiel Emanuel, which you may hear referred to currently as the antagonist against the Trump administration in handling COVID-19. Emanuel was actually present in the Clinton administration as a healthcare advisor. He resurfaced because he's Rahm Emanuel's older brother. He's the part of a trilogy of boys there in the family who are all high performers. But Dr. Emanuel was an advisor on Hillary Care, and Hillary Care has a lot of resemblance to the Affordable Care Act. So the connector in that is Emanuel and his advice and his worldview of what healthcare should look like. So both of them were promoted as the resolution to crises, all right, in education. It was the nation at risk. In PDMP, it's the opioid crisis. They both have grounding, or you might say the seeds, in the Clinton administration with federal laws that were passed there that resurfaced again and looked very similar when Obama took office. So we have the American Reinvestment and Recovery Act that funded the Race to the Top grants in education, and it also funded grants for health information technology. So you can see what's going on here. It's a very similar structure in its origins. Then the administration is also very similar in that it's people in the cabinet close to the president who are going to be orchestrating these things. And Bill Gates had a lot to do with the seeding of Microsoft or Gates Foundation employees, their management employees, into the U.S. Department of Ed to assure that grants were conferred into the states that were going to be consistent or compliant with the agenda for this Common Core initiative. Ezekiel Emanuel, again, he was the advisor to the Obama administration. And he's now the advisor of WHO. So you can see the same person surfacing there. There were modifications to federal law so that the federal government could get access to your individual level data. And Family Education Rights and Privacy Act became Swiss cheese. So did HIPAA. So that there were third parties who could access your data, that if you were approaching this from the PDMP history of 15 years ago when Missouri's legislation, first started coming to the attention of legislators. It's not the same opioid crisis, you should know that, and B, it's not the same PDMP, because the Obama administration transformed and expanded it. So it's what we're talking about, especially the PDMP in the last 2 years, is not the same PDMP that was in discussion of those hearings 15 years ago. So grants were used from those departments in the executive branch to incentivize the adoption of these things. And the National Governors Association was tapped to orchestrate governors' support for all of this. So there was the Common Core State Standards Initiative and also a drug initiative. You can see a similarity in the structures in that there were a need for consistency on a national basis. All right, so you got your Common Core State Standards adopted by every state through the grant programs. In 2016, the CDC released guidelines for prescribing opioids for chronic pain. So it was no longer a decision between the doctor and the patient. The doctor was going to be accountable now for complying with standards of care set by a group in Washington, D.C., who had no interaction with that individual patient. And the level of data that's entered into the data systems for both of these systems is at the individual level. For Common Core, for the every state, they have statewide longitudinal data systems. So there's a student information system ID associated, a unique number given to each student. And what the Clinton administration put into HIPAA was a universal patient identifier. There's a little bit of history there. It's in there. It's been passed. It hasn't been funded by because it was defunded by Ron Paul when he was a congressman. That said, there's an Illinois congressman who tried to strip out Ron Paul's language last summer. So here's the important point. This is a long game. It's been a long game for the progressives, not just since the Clinton administration, but they tried this national health care stuff since the Truman administration. It's just Clinton was most successful in getting major parts through during his administration. Obama, because of the Recovery Reinvestment Act, was able to launch a great deal more. And it's been dismantled in a piecemeal kind of way, so that it's not what Obama wanted. But here's the point. The next Democrat candidate promises to do the same thing, resurrect this universal health care agenda and either socialize it all together, which is what Sanders wants, or expand the ACA, which is what Biden says he wants. So this will not go away. The PDMP, because of those grants and the emphasis on health information technology, is still being promoted. And here's the thing.
Mary, can you check the admission?
Okay.
Are there any more need to be admitted?
Sorry. Thank you, Bev.
Okay, thanks.
They surveil data. So the statewide longitudinal data system is surveilling academic achievement data for race-based achievement gaps. That's what the National Assessment of Education Project Progress does. It disaggregates the data so that they can compare racial groups. And then there's another data set. It's not associated with Common Core specifically, but during the Obama administration, the CRDC, the Civil Rights Data Collection, was modified so that there was an enhancement of school discipline data that was going to be collected. And the assumption was if children of different racial groups were disciplined more frequently for the same infraction, more frequently than whites, then the algorithm was going to assume that this was race-based, not calculating anything else. And the DOJ and the Civil Rights Office could start an investigation and begin the lawsuit against a district based on that quantitative data. Very similarly, in PDMP, it's surveilled by the Drug Enforcement Agency. And again, it's done on quantitative data. In other words, the frequency of prescriptions, not the cause or the condition of the patient. That data is not included. So you can see it's supposed to be unbiased, but in that it cannot, because of the nature of the structure of the data collection, it cannot be sensitive to individual differences. And both of these data collection systems are based on value-added measurement. That's why teacher evaluations are tied to student performance, because they consider that value added to student learning. And you know what is invalid about that assumption is that it assumes only the teacher has influence on student learning, that there are no other factors that need to be measured. And you can see the fallacy in that thinking. Well, the value added thought or measurement for the healthcare providers, meaning the settings really, in the assumption in PDMP is, we will tie your cost savings to monetary rewards. So if you save us on drug costs, we can reward you for those savings. And you can see what that is. It's an incentive not to prescribe. So there are harms to the public in that there was a violation of public trust. There was never a pilot or controlled research study saying that these Common Core standards were actually going to improve student learning, or that they could actually achieve college and career readiness. That claim was made without any data. And similarly, PDMPs are claimed to address the opioid crisis, but that claim is made without any conclusive data saying that it's actually working in that direction. And in fact, the St. Louis County PDMP, since it was established, there's been a 30% increase in opioid deaths, and we know why. Because of the illicit drugs that the PDMP can't capture. So, you know, there's a lot of claims and hopes put onto these things, and it can't deliver because of factors outside of what it can measure. So there are harms to the individuals. I'll let you read that, but I want to point out to you that one of our concerns has been patient privacy. And recently, December of 2019, the Drug Enforcement Agency sued the state of Colorado's PDMP board for the PDMP data, and it specifically wants the names of patients and doctors. So the idea that this thing is stripped of all personally identifying information and no third party would see it is patently false. We know that it has to have that data in there. And so there's of course destruction to our constitutional rights, and other major lawsuits having to do with data collection and sharing. And I'll let you read that table later, but I want to get onto the PowerPoint so that we can finish this evening and you'll get all the information and wisdom that you can. So what we have to appreciate is that prescription drug monitoring programs have been used by different states for law enforcement purposes since the beginning of the 20th century. That's why I'm saying the PDMP we were talking about 15 years ago is not the PDMP now. Since the Obama administration, particularly 2011, the purpose of PDMP was expanded, and the real purpose is not what you've been told. We need to go back and ground ourselves in just what is socialized medicine before we can move forward and say this is actually a mechanism. It's not a program. It's a mechanism within the programs of socialized medicine. So let's go back to the Socialist Party's definition of a socialist society and see what it says government should be doing. It says the people, and of course that means the government, owns and controls, or it doesn't have to own, but it could control and manage through legislation, means of production and distribution through democratically controlled public agencies. That's where we get into the FDA and the Drug Enforcement Agency of the DOJ, so, and the CDC within the Department of Health and Human Services. You're going to see all of those agencies have some interest in PDMPs. The primary goal then of government and their goal in the control of production and distribution is economic activity to provide the necessities, which means the basics. And it means that you're always going to have the two-class system of these people who get the government provided basics, and then there'll be the people who can afford the Cadillac version that can go outside the system and pay for it. So this idea of equity among all people is another claim that can't be supported. But look at the word necessities, because that's what you get, including healthcare. And it says social services. So if you go to the next paragraph, social services includes care for the chronically ill. It doesn't mean that they're sick with a disease. In the case of many of those chronic pain patients Mary's talking about, it's an after effect of a surgery. But it does mean that they have long-term needs for pain management. So you're planning, what happens is they're going to provide these social services, but it says the planning takes place at the community, regional, and national levels. Note that's no longer between you and your doctor. The planning is already established in standards that are set by a committee of experts somewhere foreign to your immediate situation. And it's determined democratically. So hold on to that, because you're going to see consensus come up again and again. There's a consensus about things. A consensus cannot be sensitive to individual differences. But hey, when you're dealing with society rather than the individual, it's the consensus that's going to win. So here's our position and thesis that we're going to develop throughout the PowerPoint. It was Obama's Affordable Care Act that included funds to reform healthcare with health information technology. In 2011, the Obama administration's Office of National Drug Control Policy, and that was established in 1988. That's not a new office within the executive branch, but this particular group in 2011 instigated an aggressive plan to establish PDMPs in every state. So you didn't have that urgency before. This was an Obama agenda. Every Democrat running for president in 2020 embraced a healthcare system. Note that word system, because the system will be standards, evaluation of performance, and data collection. That's the system. The federal government will structure and finance universal health coverage. The key person connecting Clinton with the Obama plan is Ezekiel Emanuel. He was special advisor to the Director General of the World Health Organization. He was advisor to the Clinton Task Force, and he's the chief architect of the Affordable Care Act. Now, remember, he's up there in the World Health Organization. So he's advising what the policies should be. And the agenda of WHO for the member states, and the United States is one of them, is to provide universal health coverage. So you can see where the Democrat platform is consistent with the World Health Organization. And a national health implementation technology system to support collection for surveillance. When Ron Calzone used that word surveillance, everybody thought it was conspiracy theory, but you'll see surveillance come up again and again in the PowerPoints. And that's because most of them I take as screenshots from the original source, so you don't think I'm making this up. But the ultimate goal is not compassion for the individual. The goal is cost control for national economic viability and a healthy workforce for making society flourish. That's an entirely different worldview of what the individual is in relation to its government. So if we're coming off of a constitutional republic as described in our Constitution, then we're at odds with what the goal is from the UN. The PDMP then is a component of medical information that will be merged with school collected data, and I'll show you the slides for this, in the statewide longitudinal data system. And then that SLDS will be merged with workforce data for the Department of Labor. So then what you have, when you hear cradle to grave, they mean it, cradle to grave data collection. I want to show you that this is the original platform that Obama ran on, the 2008 Democrat platform. The statement within that platform says, our vision of a strengthened and improved healthcare system for all Americans stands in stark contrast to the Republican parties. That's why when I met Majority Floor Leader Lovosco, I said, no Republican should be voting for an Obamacare component. So what we're looking at here, it says the government is going to have this responsibility that all Americans get coverage. It should ensure that health insurance is affordable and provides meaningful coverage. And note that it says individuals should purchase it. We all remember what the individual mandate was, but it was a coerced mandate that everybody buy insurance, because that's the way, A, you can fund the system, and B, you can get everybody in the system, because they'll then be designated a number. So the point for all of this, and he says it right there in the platform, is aggressive efforts to cut costs. You're going to drive the adoption of state-of-the-art health information technology systems. For PDMPs, they did exist, but they were expanded. And in particular, I'll show you that direct source. So it says privacy protected electronic medical records, reimbursement incentives. That's what the healthcare settings will get. They'll get the money if they cut the cost to the government. And an independent organization to review drugs. I want you to take a good look at what Ezekiel Emanuel wrote in 2009, the first year of Obama's administration. He's writing what was called in a Wall Street Journal article, the Reaper curve. He's describing the probability of receiving an intervention according to, and look at the caption under that graph, age-based priority. So what you can see is the curve for the very young. If you have a disability or a difficult birth, you can see there's a lower probability of getting intervention. And clearly after working age, by the time you're 55, the curve is going to drop off deeply. And you might think I'm, a little extreme in saying it's all about the workforce, but look at the text from the article. It says the well-being of some age groups, we argue, is instrumental in making society flourish. Therefore, here's the key word, collectively, we would make the argument that although used to justify age weighting, would equally justify counting life years of economically productive people. and those caring for others. Okay, so it's about the workforce. Here's another thing Emmanuel wrote. He says, we're going to standardize at consistently high quality standards, interpreting all components of care. You got it? Drugs. The next red line, red set of text. They will have standardized, guideline-driven care plans for most major conditions. That's where it's no longer a personal decision. And they're going to harness the electronic records and identify patients. Hang on just a second. Let somebody in. Identify patients who will become sick. So they're looking at probability algorithms, okay, and how to care for well-identified chronically ill so as to reduce costs. Hold that thought, because Mary can tell you more about just how that gets done. So what Ezekiel Emanuel is after is a reduction of drug prices. He said we would cap the price based on objective quantitative measures of value. Measures of value are going to be captured in the data that's submitted through PDMPs. The private payers would continue to negotiate drug companies over prices, but there would be a ceiling, and that's where the socialized, the force of government comes in. Here's how it plays out even now during the COVID-19 epidemic. So in the state of Washington, everything we just talked about, listen carefully to this article published in the New York Times. There's a triage document under consideration that will assess factors such as age, health, and likelihood of survival. The effort to statewide is so individual doctors and hospitals will not be left to make decisions. So they've got to do it according to the manual. It's protecting clinicians so you don't have one person who's playing God. No, it's a committee. A committee's playing God, and they're somewhere distant from the patient. So they look at criteria. In this case, it would likely be age and underlying disease conditions, and then determine that this person, though this person has a chance of survival with a ventilator, does not get one. This is a shift to caring for the population. So it's a shift from the individual, whoever comes to you with need, to saying, okay, do you fit the profile of who we can care for that will help our society flourish after this is all over. Those who have a less good chance, she didn't say no chance, a less good chance of survival, but still have a chance, you do not provide care to them, which guarantees their death. So again, linking Ezekiel Emanuel, what he wrote, to what's going on in Washington, to what is recommended by who. If you go over to the left side of the slide and look into the gray box, you'll see what's highlighted. Member states facilitate improvements in ordering, prescribing, preparation, dispensing, administration, and monitoring practices, which would be adopted by those member states. You can see this aggressiveness in the Obama administration's establishing of these PDMPs nationwide, okay? And here's what, if you're familiar with the schedules in the bill, Schedule 2, 3, and 4 drugs in Holly's bill, that's what would be monitored by Missouri's PDMP. Missouri didn't get to make that up, nor did the US CDC or the Food or Drug Administration. Those schedule lists of drugs are determined by an international treaty that's under the UN, the World Health Organization. And highlighted in that box then are narcotic drugs in forms A, B, and C will be submitted in Excel spreadsheets wherever possible. So you can see why there's this huge pressure to get health information technology. I call your attention to the next slide, which was a paper presented to a national pharmacy organization. And what it's suggesting is nationwide prescription drug monitoring. And here's the point. As much as they say that PDMPs are managed by the state, there is and will be a movement to nationalize all of that. And you can easily do that with the interoperability and the exchanges of information. This particular paper is confirmation that the PDMP were originally designed for law enforcement, but they were secondarily facilitated for public health concerns. And that was basically during the Obama administration. This is from the National Institute of Health. It talks about, again, it's the same year, 2014. That's when the real push was on, to redesign the electronic health record, incorporating the use of other clinical tools, meaning PDMP. So the PDMP data will not stand alone. It will not be in a separate silo. The whole idea is to merge this with electronic health records. And it's being suggested, even though PDMPs have not been well studied or widely supported for the use that they're claiming. This is, here, look at the top, a consensus study report from the National Academies of Science, Engineering, and Medicine. And the name of the report is Pain Management and Opioid Epidemic, Balancing Societal and Individual Benefits. We never heard of that before. It was always about taking care, a compassionate approach to patient care. But now you have to consider what will be the larger effect on the whole society. So note that this committee, it was a committee, just like what was said in the Socialized Society opening slide. So it's a committee that's going to make these recommendations. And the question put to this committee is, what should the FDA and other government aid entities do to further society's collective interest? It specifically says the committee was not charged with asking what physicians and other prescribers should do, or what options should be available to the patients. They weren't dealing with the individual level. They were dealing with societal collective interest. There's no significant difference in the rates of opioid overdose mortality and the rates of opioid drug use between states with or without PDMPs. That was reported by this committee in a 2017 publication. So we're moving forward at breakneck speed, and we don't have evidence that will justify A, doing it, or B, not rolling back what's already in place, because the claims for it either aren't true or there's got to be another reason they want these PDMPs. So the committee recommends that the U.S. Department of Health conduct or sponsor research on how data from these programs can best be leveraged. In other words, we don't know. Okay, that's the translation. They're moving ahead and they really don't know what they're going to get out of this. But having data is good. That's the value there. You should be aware that just 2 years ago, it says Rep. Walden Gregg is an Oregon Republican who sponsored this bill, Support for Patients and Communities Act. And the support had to do with dealing with the opioid crisis. Note that within this bill, and it's anybody who takes money from the feds is going to be mandated to meet the conditions of this bill. That's what was scary about the Senate substitute. It set up a task force and then authorized the task force to apply for grants. If they apply for federal grants, you can bet your bottom dollar it's not the state of Missouri that's going to be determining the terms of the structure and function of that PDMP. It will be the grantor. So one of the mandates is that the state's Medicaid program have access to the PDMP data. And it says that any substance required by the state to be reported in the PDMP would be accessible. So here's what's scary. 2 years ago, the state of Nebraska expanded its PDMP so that all prescription drug information was going to be reported in the PDMP. And it prohibited any patient from opting out. And it included the patient's name, address, telephone number, gender, and date of birth. Any hacker can put that together and and start, identity theft. So that's very scary. And then just this year, the state of Maine also expanded and renamed controlled substances to prescription monitoring program. And it specifies that any drug dispensed to any person in the state would have to be reported into the PDMP. Now, this prescription drug monitoring program slide that you see now, the Training and Technical Assistance Center, that's in Brandeis University in Pennsylvania, funded by the Department of Justice. And here's what it says about the status of message standardization between people who would be accessing the data within a PDMP. The data is available, if this request is complete, data is available and returned for a person that matches the requested patient. So again, all of our concerns about personal privacy are justified because the documents of the programs that are either establishing or consulting with or requiring PDMPs are requiring this personally identified information. So if you've never seen what the flow of information might look like, the PDMP would be a repository of data, even though in the Senate substitute bill, it says the government will not have the repository. It doesn't matter. The board, it's the PDMP board, whoever they hire as their vendor, would be responsible for authorizing a release of that data, which is going to be important to us as we discuss what's happening in Colorado, because like I said, that the DEA is suing the board for a release of that data. So far, the board is fighting the DEA because every person's information is in there, and what the board is saying, so who are you looking for so we can narrow down the search and not give you everybody, and the DEA isn't satisfied with that. That's our problem. Here's something you should know. Remember that the Clinton HIPAA bill established the Universal Patient Identifier. What's going on here is a trade organization, the National Council for Prescription Drug Programs, is announcing that it just got support for the application of communicating between that Universal Patient Identifier and the PDMP. That's why I say the PDMP data will be merged. It won't be a separate silo. It will be merged with other health information. I have to put this in there because, again, it emphasizes there's a long game here. Ronald Reagan warned in 1961 that there would be statism or socialism by way of medicine disguised as a medical program, and that the medical program will be sold as a humanitarian project. In other words, it's going to solve a crisis. So socialized medicine, he says, if you gave the American people a chance to vote on it, they wouldn't take it. But that's the deal. And you remember it when Nancy Pelosi said, you're going to have to pass it to see what's in it. The whole point is, the nation would be provided that mechanism for socialized medicine capable of indefinite expansion in every direction until it includes the entire population. That's why I showed you Nebraska and Maine. Now here's a clip out of the Race to the Top application, and you can see what's highlighted in there. The Missouri Comprehensive Data System will include components such as medical information and career information. Now, if you go to the Department of Labor website, it says that education data being collected in the statewide longitudinal data system is a parallel effort with what the Department of Labor is doing. The long-term WDQI and the statewide longitudinal data systems will follow individuals. They're not talking collective here. They're not talking aggregate. They're saying they'll follow individuals through school into their work life. So I hope I've made the point really clear. PDMP is destined for something that it was not 15 years ago, and it will be part of this whole agenda that uses the technology that's being put in place to merge the data with other silos of data and create a profile on individuals. So who's responsible for this? Of course, we've talked about Clinton, Obama, Ezekiel Emanuel, Pelosi, Jonathan Gruber, and Bill Gates. I'll just review a little bit more. It started with Clinton when he pushed his universal health care. Hillary Clinton, of course, suggested, and what's important here is that there's different versions of socialized medicine, so it's not all what Bernie Sanders thinks. What Biden is suggesting is still socialized medicine, because you have a huge government control on what people can buy, and it's promoted as what people can save. But don't be fooled, because what comes along with that package is standardization of care developed by experts who make decisions about your health care, and it's no longer in the hands of you and your doctor. Barack Obama, of course, picked up on this universal health care agenda. He wanted mandatory health insurance, and clearly the big part of ACA was the adoption of this health information technology. Of course, Ezekiel Emanuel was his special advisor on health policy to the director of the Office of Management and Budget. Doesn't that sound weird? You know, we're not talking Department of Health and Human Services. He's consulting with economics. And we have another economist, Jonathan Gruber from MIT. What Kathleen Sebelius's Department of Health and Human Services did was give Jonathan Gruber a sole source solicitation. In other words, it was a non-competitive contract. And so here's the background of Ezekiel Emanuel according to his own bio. He is a member of the Council of Foreign Relations and chair of the Future of Healthcare for the World Economic Forum. That's why we keep coming back to systems theory is grounded in economics, not in a worldview that views the individual as having inalienable rights, including the right to life. His plan is to end health insurance companies, that they'll have accountable care organizations. Of course, they'll be accountable to the standards that are set at that higher level of policymaking. The organizations would make money keeping their patients healthy and minimizing the costs of care that is prescribed for them. Jonathan Gruber, you may remember there's a huge flurry about, he did get this sole source solicitation. And what he said about his own bill was that lawmakers and voters didn't know what was in it. And it's that lack of transparency that gave him a huge political advantage. And then he called us stupid. He's deceptive, and then he called us stupid, but he really wanted the thing to pass. So I think that's kind of indicative of the whole thing. Of course, Nancy Pelosi was helping with the deception and the cloak of darkness. You have to pass the bill so you can find out what's in it away from the fog of the controversy. She didn't say, because this was the socialized medicine we tried to get under Clinton and failed. Again, Bill Gates doesn't have a direct line to PDMP, but if he's funding the World Health Organization and they're the ones who are interested in this surveillance of prescription drugs, then you can see the connection in that he's helping to prop up, because World Health Organization has financial problems, but he's helping to prop it up to continue this dissemination of what it means to have universal healthcare and a socialist agenda. What it does say in a 2002 resolution, so this was 2 years after Bill Gates started his prolific funding of the World Health Organization, develop global norms, standards, and guidelines. That's what we were talking about that Ezekiel Emanuel was promoting, and compliance with those guidelines. And that's where you get this coercive um, operation in chilling doctors from prescribing. This is a copy of the cover of what are called the CDC guidelines for prescribing opioids for chronic pain patients. What happens is that the doctors, in fear of being surveilled for a high frequency of prescriptions, regardless of what the healthcare needs of their patients were, they either underprescribe or they abandon care, and they just kick the patients off the rolls, and the patients go without care for their health needs. So in some, then the PDMP is the Common Core of healthcare. It was introduced as part of an ideology that came from not the grassroots, not necessarily generated by an observation of patient needs, but an idea that the World Health Organization had and the Truman administration had in the 1940s to provide universal health care. So if we go back 60, 80 years already, we can see they're playing a long game. It surfaces again and again, and the PDMP is a part of that. Together, the Common Core and the PDMP comprise a public-private partnership agenda to ensure healthy population of working age, of children who are prepared then for human resource development. That's what it says in Mark Tucker's letter to Hillary. That's what Common Core claims it can do, is create a population of kids who are college or career ready, even though there was no data to say what kind of colleges or what careers. They just had a great marketing campaign. So it's to populate the workforce for the benefit of the national economy rather than the individuals. To hold individuals hostage and force their consent. That happens in both scenarios, education and PDMPs. If you want access to your public school services, you could, as a parent, you have to click a box that says I consent, but you really can't move forward anywhere on the web pages until you click that box, and there's no option to say no, thank you. The same thing happens with PDMP. You don't get your meds unless the doctor's taking your personally identifiable information to upload into the PDMP. So in both cases, we've got algorithms and computers making decisions for us rather than that person-to-person decision making that we cherish, not just in our relationship with our doctors, but in the social contract we have with our government as well. So that's the end of the PowerPoint. I'm happy to take questions. Mary, I talked kind of fast to get it all done. Did you see anything that needed
clarification?
Attention.
I just really want to thank everybody that is on the call and that they are intently listening. I hope that they get the gravity of what Mary Burns has found and what a victory, or I want to say how amazing it is that we in Missouri have the ability to possibly prevent socialism and socialized medicine. And it's a very unique situation because we are the only state that does not have a PDMP. And when you implement a government program, it doesn't seem to go away. And we need to prevent this, because this, as a pain patient, is crucial, because you don't know who, as you age, who will be those type of people. It could be you, it could be your kid, it could be your grandchild, and we have a right to the freedom of medical care with our doctor. It's imperative. And this is basically, no, it is the government taking over and telling doctors how they will treat you, and if you qualify or if you're able to be treated. So it takes the thinking out of the doctors, and when we lose that ability, we lose innovation, we lose creativity of medical advancement. It's a major find.
Mary, can you explain, because Missouri is the final link that they need to complete the standardization
Yes.
and the compliance. So Mary Burns or Mary Kramer, explain that, because that's why it's so important that we do not let this pass this year or next year. The more information, now that we have so much information, we can actually start educating people, that we can even hopefully have counties in Missouri that have adopted it to repeal it once they know, the
Right.
The critical.
Mary, do you want me to? I can start out as a patient, and then Mary can also fill in too. As a patient, we are looked at as we cost the system money. Even though I work and I pay taxes, other people that I know that were able to work and can no longer work because they can no longer get their meds, because there are doctors afraid, because other states are having the DEA and the DOJ attack doctors and put them out of their practice and take everything that they've worked so hard for. So Missouri and the county systems, if Missouri, see, we don't have a law, we have an executive order. So if this becomes a law in Missouri and we now fit that puzzle, the Senate substitute, if you read it, it is written so loosely that it can be manipulated and adjusted to fit any agenda. And so how that fits into the piece of the puzzle is that if they have all 50 states, and remember she said they have gone into other states. An example was Colorado, and they sued the pharmaceutical board that holds the data for the state of Colorado to get the information. And the state of Colorado had to deal with the federal government, the DEA, in order about getting the patient privacy information. And the government will get it. And so by completing Missouri, they will have everyone in the United States. And then by putting in all of the medications like Nebraska and the other states, we now will have a very, very detail-oriented way of socialized medicine. It's the piece. We are the piece of the puzzle. Mary, you have anything that you want to?
Well, just that by definition, if you have a universal healthcare system, you can't have outliers.
Right.
You have to have everybody.
And if we weren't, then that we would throw the numbers off to where if we are in that, there is no numbers to compare it to.
You're a control group. So
exactly.
If Missouri was doing something right, and let's say we were able to reduce opioid deaths by walling out the fentanyl coming in from China or up through Mexico. Let's say that we had data to support. It wasn't the PDMP that stopped our opioid deaths. It was an aggressive program of other measures. And that's my point, is that by focusing on PDMP and saying this is going to be the tool to, and everything I've read only calls it promising. There is
Yeah.
nothing definitive to say this works. So, and that's what made me think, yeah, that's like Common Core. They had no proof, but they went ahead, not based on data saying this is what's best for the healthcare of our people. They went on an ideology saying universal healthcare is our goal, and not examining what the components of that healthcare might look like to the best advantage of individuals. So, you know, I get what they're going and trying to control healthcare costs, but they've redefined what the relationship is between people and their government, which was not part of the package. And they're not telling you that. So that's our concern. And yes, they're using this data, you know, to research. When they say value, they want to know if less drugs are given and you get a different kind of intervention, does the person get healthier? Well, we'll find that out. So
That's
they're
right.
willing to make you suffer for their agenda.
That's right. And that's in the Affordable Care Act, that they are actually studying chronic pain patients, because the idea was, when the CDC guidelines were written, there was a group called PROP, Physicians for Responsible Opioid Prescribing, that very rapidly drew up the guidelines with no evidence to support it. And these doctors all have financial gains in this whole agenda, threw this out there to see what would happen. And the idea was they could see that chronic pain patients were on opioids, but yet not everybody could be functional or workable. So there are some people that have chronic ailments that will not get better and that they cannot function. And there are plenty of other ones that were taking medicine and being able to function and work. And so they wanted to see if there was other things that they could do or introduce in different stages, and see if there's a way that they could reduce the opioids and get us back to work. But it's really had a very detrimental effect to so many of my friends who are no longer able to work, and they're bedbound, and these people are committing suicide. And if a patient moves, there is no doctor that wants to take them on. They're using the PDMP in other states as a way to look at the physician prescribing practices, and they will bring them to trial and send them to jail and take all of their possessions. And the PDMP is used in the trial to look at the physician's prescribing practices. So you don't want to be that top prescriber. And so that's the thing, is that doctors have been cutting due to, remember, they work for hospitals and they have practice liability. So physicians are losing their rights to be able to treat patients as they want to, which is highly frustrating. So it's also less doctor-patient time, less chances for solving and creating cures or finding the real source of the problem, which is, again, going back to, let's just prescribe a pill. So this whole idealism about what they're trying to sell it on, addiction and saving lives, isn't really in the PDMP. If you read the PDMP bill, it's more about punishment than it is about really anything else. And it's so loosely, the Senate substitute, this is not an amendment, this is a totally new bill. It is written very loosely, and it definitely can be morphed into whatever the federal government with the grants want to do.
Or other
Mary
private
Burns.
funders. Yes.
I was going to ask you to give the analogy of the Parkland shooting and the data, because it explains it so well. When all they are looking at is data, that's why the doctors are not prescribing the opioids, because they just look at who's prescribing. The same way as the school districts. The school district in Parkland was dishonest with their well, not dishonest, but was lax in their discipline.
Well, what they did was, by not entering data, you have nothing to report and they have nothing to surveil. And so the boy down there, Nicholas Cruz, had many run-ins that were actionable, you know, in terms of threatening other people with guns, or physically assaulting even his mother. They knew that they frisked him every morning to check his book bag for guns, because they knew who he was and what he was capable of. But it's all about the data. So you need to keep your enrollment up with the number of students in attendance, and at the same time, you don't want to report discipline action that may make your figures rise, that you have to report to the civil rights data system. So you just don't report, and you don't discipline. You don't do anything because you don't want to take the risk of being accused of racism. And so this guy got away multiple times with things he could have been diverted to the justice systems for. But that's what they're all about, is what's called delinquency diversion away from the justice system. And because of that, he had a clean criminal record, and anybody who did a background check, and he bought several guns, would not have found anything, because the school was making sure its data wouldn't incriminate the school district, regardless of what they knew about Nicholas Cruz. So similarly, doctors will not treat patients, or and I'm not saying every doctor is an angel, but you know, Dr. John Lilly, in submitting his article, found that 2.5%, I think, of patients go to a second doctor. Now, is asking for a second opinion the same as doctor shopping? I don't know, but how do you distinguish that in your data if the same patient shows up, you know, in two different offices? I know for a fact that getting a second opinion is beneficial at times. And I don't know how that data is programmed, that it might be so sensitive that it distinguishes the motives of a patient who goes to several doctors.
The county system that's incorporated right now has a flagging system that takes the human thought out of it. And so what happens is a patient that was on opioids had an emergency procedure, and you sign up that you're going to this doctor in this pharmacy, and had an emergency procedure, so had a surgeon prescribe more opioids before they left the hospital, and had the hospital pharmacy fill the prescription. So when the patient left, they were flagged for doctor shopping and pharmacy shopping, because it was a different pharmacy and a different doctor that prescribed, even though both knew that the patient was already on opioids. And the flag notification's not sent to the patient, and the patient, we're not given any notification that we're in a PDMP or not. And they couldn't find another doctor to help them. And finally, a doctor, after a referral, had said, "You're flagged." And it lasts for 6 months. There's nothing that you can do. It's not as simple as querying the system and the doctor decides if they want to prescribe or not. They have to jump through a lot of hoops. So what happens is doctors don't prescribe and the patient suffers. And that's Missouri. If you call them, and you talk to St. Louis County, they will tell you the system is flawed and they know it, but there's no way that they can remove a flag.
Well, and the application for the rest of us is, if Nebraska and Maine are setting a trend, the PDMP bill that you passed today is not, with the picture in your head of what that PDMP might be, is not necessarily what it will be even 5 years from now, if it's the task force in charge of it and there's no legislative oversight. There's no consumer representation on that board. It's all experts from existing boards within the state bureaucracy. So, you know, really the people most affected by this bill have no voice in it.
Right.
In the existing bill, while it covers schedules 2, 3, and 4, covers more than opioids. It covers the Ritalin and the sleep aids and the antidepressants. So right now, even our present proposal is bigger and more ominous than the just the opioids.
Yes.
Those schedules represent different levels of addictive liability. So Schedule 1 is considered non-medical and highly addictive, and that would include drugs like heroin. Schedule 2 have a medical purpose and are highly addictive. So that's where they put the opioids in there, and Ritalin and Adderall is a Schedule 2. And then Schedule 3 is has a medical purpose and is less addictive. So, but what all of the discussion has been about is opioids, and they never explained why all of the other schedules were in there too, 3 and 4. What was that about? So the claim that this is just a tool for dealing with the opioid crisis is not transparent. There's other things involved here. And like I said, the lesson for us is the progressives play a long game. This has changed over time. It will continue to change over time. And it looks like the direction is heading is including all prescriptions for all people given in all settings. And if it becomes nationwide, if it becomes interoperable nationwide, we're not looking at a state managed PDMP, we're looking at a federally managed PDMP. And that is your ultimate socialized medicine. And I showed you the paper where that's being promoted. That's an idea that's floating out there already. I'm not making it up.
Yeah, they want that. There was someone that mentioned, Alyssa mentioned, what you just said, Mary, should be one of the first things you talk about to get the attention of the legislators, talking about no oversight and representation, which is correct. That's a good point.
Yeah, Alyssa just made that comment. So thank you, Alyssa. Yeah.
Okay. So any other questions?
Does everyone seem to understand that what we've kind of all been kind of against was our, being able to have rights, and we were getting, freedom and the data storage, and the pain patients were getting hurt and doctors were having problems. But this is a bigger picture.
Yeah. Now we have the link. that proves it's worse than we thought. I mean, we're opposing it on principle all these years, but now we have the link. Oh, and the damage it's doing to the pain patients. Maybe we should bring everybody up to date on where we are on the Senate Substitute 16 of House Bill 1693. It came back from the Senate before they left town, and now I guess I haven't seen anything yet. The Senate is in today to deal with the supplemental appropriations for the COVID-19 situation, and the House, I understand, is supposed to be in tomorrow to contemplate whatever the Senate sends back to them. So this this week we're pretty sure that we're safe because they're just going to go in there and deal with supplemental. Now, we are told and we expect that by the end of the month, the General Assembly, the House, will be back in to deal with the budget, because the budget has to be passed first week in May. So at that time, you know, we've looked at the schedule, and it's very, very likely that they'll be bringing up the Senate substitute of House Bill 1693. We really thought they were going to bring it up on that Wednesday, March 18th, when they met, and it was actually on the email of things that they were going to discuss that day, but thankfully God intervened, and there was enough rumbling going on and enough opposition to the Senate substitute that the floor leader, Vescovo, did not bring it up that day. So we have time to work on this, and Mary Byrne has jumped in with both feet. Mary Byrne and Mary Kramer both have worked very hard on this presentation and getting our ducks in a row. And we've had some House members are also helping to strategize. So the plan is we're hoping to make another presentation, much simpler probably, to the members of the General Assembly next week. Mary Byrne was making her presentation scaled and targeted to the office holders. And then we're going to be asking, we're going to be trying to do a lot of Facebook, social media attention to this, because we need to show the representatives need to feel the heat from their constituents, so that they will go to floor leader Vescovo and ask them not to bring it up. They're getting too much heat from their districts. Representative Vescovo has always been a no vote on this, on the PDMP anyway, so we have that much to go on. He does not like the bill. However, they feel like they owe Holly Rader this bill to be passed this year. This is her last year in the House, and she is running for Senate. So she is putting the pressure on to get this passed so that she can carry that in as a victory as she campaigns for Senate. So we have lots of different things working together, but thankfully, you know, Vescovo does not like the PDMP, but he does like Holly Rader. But if we can, we have, oh, I forgot the number, 49% of the Republican members have voted against House Bill 1693 when it left the House back in early, oh gosh, what was that? I guess February. Yeah, and then, so we have, so 49%, and I did know those numbers, 49% of the Republicans are already against it. So we're working to get 16 of the yes votes, Republicans, to switch. So anyway, so we will be sending some information to everybody for the steps that they need to take, as far as we can show you who were the yes votes and who are the no votes. I made a spreadsheet that compared the last 2 years' votes, both because we had freshmen last year that voted on the prescription drug monitoring program for the very first time. So we'll be in touch with who really needs to be contacted. In fact, members of my legislative team, I think all of us have reps that voted yes on it. So if each of us are sharp enough, we'll have 5 no votes. Mm-hmm. But so anyway, so just, you know, stay tuned, and we need just to create the heat, because I think, you know, we have, sadly, we've depended on the Senate to kill the bill all these years. This year, we knew that leadership was intent on getting it passed, demonstrated by how early in the year they were dealing with it. They've never dealt with it this early in the year. And for it to come out of the Senate with a compromise this loose is really pretty scary. But thankfully, like I said, God intervened, and He's given us some time, and we have a chance to defeat it this year and live again to defeat it again next year. I had something else I was going to say, but I forgot what it was. Anyway. Oh yeah, because we depended on the Senate so much, we really weren't creating the stir out in the state that we really should have. You know, whenever we posted something, you know, there's been a whole lot of comments on social media regarding this COVID-19. And so I need to go back, and every person who has been a little bit skeptical of the medical profession are prime people to be contacting their state rep and with their opposition to the Senate substitute of House Bill 1693. So we really need to stir up, because the reps really have not heard from their constituents, because when they go back to their districts and they talk about having passed the PDMP because they need to do something about opioids, because it's passed the House every year except one in the last 7 years, and they tell, you know, the people just what they want them to know about it, and that's, we have an opioid crisis, and this PDMP is going to help solve it. So the people back home, I've known in my own experience, when I've explained the just some simple parts of the PDMP to a person who thinks that they support it because they've been told it's going to alleviate the opioid crisis, when I tell them that it includes more than just opioids as far as the schedules, and I tell them the physicians do not have to check the database before they prescribe, and that the pharmacist does not have to check the database before he or she prescribes, then they say, well, no, that doesn't work. You know, so the common person out here just thinks that their rep or senator is doing something, but when they find out the details of the bill, then they get annoyed. So anyway, so we just need to let the people of Missouri speak loud and clear on this, so that the House feels the heat and they don't bring it up and pass it.